Hello and welcome to Cromwell Hospital's latest online health talk on winter sports and knee injuries. Please ask your questions. Please ask your questions using our chat function. The panel will try and answer as many questions as possible for the end of the webinar. Please be aware that we will be sharing images and videos from surgery during this talk. This talk is being recorded and you will be sent the recording tomorrow morning. I'd now like to welcome our expert panel, Mr. Khakha and Brent Cohen. Mr. Khakha is a consultant trauma and orthopaedic surgeon with an exclusive interest in disorders of the knee. He has particular expertise in knee joint preservation surgery, including cartilage repair, ligament reconstruction, and osteotomy surgery. He has been fellowship trained in unicompartmental joint replacement, total knee replacement, and revision of failed joint replacement surgery. Brent Cohen, Senior MSK Physiotherapist, is part of the expert physiotherapy team at Cromwell Hospital. The musculoskeletal physiotherapy service assesses, diagnoses, and treats a broad spectrum of musculoskeletal conditions. And I'd now like to hand over to our expert panel.
Hattie, thank you so much for that brilliant introduction. As you say, my name is Raghbir Khakha. I'm one of the knee surgeons here, and I'll be starting off with a presentation. The best way that these things run in my experience is if it's interactive, and I find that it's really nice to have, Brent here as well, because we work as a team. I do all the work that I do is only made to look as good as it can be with the aid of the physiotherapy team. So, we're all sort of small cogs as part of the bigger machinery. So during the talk, Brent will be jumping in and just offering his comments and experiences with managing from a physiotherapy perspective. But I would really love it if you guys had any questions. You could put it in the chat. Either myself and Brent will be sort of going through the chat while we're talking, and we can always go through the questions as we go along. Or certainly, if you want to wait to the end, feel free to do so. But the key message is please don't be shy. I don't want it to be a boring lecture just coming from me. I want it to be interactive and just not sort of hearing the sound of my own voice. So if everyone's happy, I'm going to start by sharing my screen. Brent, did you want to add anything to that? Are you happy to?
No, I'm pretty happy. I think the interactive thing's kind of what we're aiming for. So if there are questions, certainly fire them off at the time, and we'll keep it. It'll keep it more relevant to what we're talking about at the time as well.
Fantastic. Okay, so this worked earlier, so it should work again. So share screen. Okay. Here we go. So, as Hattie kindly introduced, we're talking to you today about winter sports and knee injury prevention. My name is Raghbir. I'm a consultant orthopaedic surgeon based here at the Cromwell Hospital. Hattie already gave me an amazing introduction. I'm a dedicated knee surgeon, so I do everything around the knee joint. So whether that's ligament surgery, joint preservation surgery with cartilage and osteotomies, or joint replacement surgery, whether that's partial or total. I cover both adults and pediatrics. I've recently just stopped being the head of trauma at my NHS hospital at Guy's and St Thomas's, so I do a lot of trauma surgery as well. I'm part of the OS clinic, so this is my group working out of the Cromwell Hospital. I'm currently the co-scientific chair of the Sports Society in Europe. So we're welcoming over 4,000 people coming to Prague next year, just to come and hear about the updates in sports surgery. I myself am really interested in publications, so I've had over 50 that you can find on PubMed. And one of my latest roles is that I've just taken over as the Honorary Secretary for the British Association for Knee Surgery. So I do find time to look at patients and do procedures too, amongst all these other things. So let's get into the talk. So what are we talking about when we talk about knee injuries and the ski period? Well, to be honest, we're mostly looking at ACL ruptures, as I'm sure you all know, and we're also looking at meniscus injuries. We'll look at how often it happens, how I assess, what are the current programs to prevent this happening in the first place. We're not going to talk about a huge amount on surgery, but I'll just show you a few things that we do that are a little bit different, and hopefully then we can have some questions at the end. So we are essentially talking about this 2 to 3 centimeter bit of collagen that is between the femur and the tibia. This tiny piece of collagen, the ACL, is probably the most published on ligament in the entire scientific literature. It sits within the knee joint. It's said to be extrasynovial, and essentially it goes across from the tibial eminence up until the medial wall of the lateral femoral condyle. It actually moves a lot. So even in extension, when it was relatively taut, you still got about 2 millimeters of excursion. However, when you're in flexion and you're putting on some anterior load, it can move up to 5.5 millimeters. So when you talk about how much movement there is in the knee joint, in the ACL, it's all dependent on the position that it's being tested in. In a ruptured ACL, this dramatically increases. So at 30 degrees of flexion, when we're doing our Lachman test, it can translate anywhere between 10 to 15 millimeters. However, when you're sort of going beyond 30 degrees of flexion, you've got other muscles which get involved, and that excursion might reduce. So in my hands, doing the Lachman test is the most sensitive way of picking up an ACL injury. Here it is again. Most people think of these ligaments as being tubular structures, but you can see from a side profile, it's actually it's more like a ribbon-like appearance. This is the anterior horn of the lateral meniscus, and it sort of blends in nicely. You can see the medial meniscus coming round, and normally around the front when we're doing the procedures, there's a ligament that joins the 2 anterior horns of the menisci together. So we know that ACL injuries are on the increase despite all of the really good prevention programs. And that's because there's so many people doing more sports. You're doing sports a lot earlier on. So some of the children that are training are starting really early. They're training all year round on different types of pitches, but also we're a bit more aware of these ACL injuries. So as the awareness increases, we also pick up more ACL ruptures. We know that some people are more predisposed to getting ACL injuries than others. So you could be hyperlax, you've got a greater instance of ACL injuries, or indeed it could be an anatomical feature where the shape of the tibia, the so-called increased slope, puts you at a 12-fold increased risk of ACL rupture compared to somebody who's got a normal tibial slope. And then it could be related to the kind of sports you play, which are high risk, the weather that you're playing in, but also, as I mentioned, the surfaces that you're playing on. So whether you've got good footwear or indeed the kind of pitches you're playing on. Now, there are loads of new, there are new ones, but there have been well-established programs in trying to prevent ACL injuries. In the UK, the Power Up to Play program, this has been endorsed by BASC, the society that we run, is one of the more recent ones. Activate training is really well established, and there are lots of different sports protocols depending on the sports that you do. The most important thing from my perspective, particularly with skiing, is not just going straight into a ski season having done no training whatsoever and no conditioning beforehand. So getting somebody to look at you, see where you are weak, where you might be weak, or where you need some strengthening is always really important in my opinion. Patients often ask me about braces to prevent themselves having an ACL injury. And, braces from my side they can help, particularly if you've had a previous ACL reconstruction, but there's limited evidence to support you rupturing your ACL in the first place. Brent, can I ask you just to comment on your sort of, seeing patients before they go on a ski trip, or if they come and see you, sort of for advice, what do you typically speak to them about and work on?
Yeah, I think the big thing, like you mentioned, is the strength and conditioning prior, making sure that there is adequate strength around the knee in particular, and endurance too, because a lot of the time if you're going skiing, it's not just going to be one day, you might be there for 2, 3, 4 days a week, even longer. So you need to make sure your muscles are up to that level. It's not just the knee as well. You need to be looking proximally, so going further up towards the hip and the core, but even further down the leg, to make sure that there's appropriate strength and your body's able to do what it needs to do. And it's not at a greater risk, or it's not as much of a risk of injury from happening in that sense.
Yeah, and I think you made a really important point that it's not just the knee, and a lot of people come and see me will be obsessed and focused around the knee joint, but you briefly said about the core strength being really important prior to heading off, and I completely agree with that.
Yeah, very important, very important.
So I used to work with a few surgeons, Adrian Wilson, Paul Tricker, and there was a physiotherapist, Ben Wild, that I worked with. And we this was now coming up to 7-8 years ago. We were really early on, relatively speaking. So before Power Up to Play, in introducing these exercises, which act as a warm-up prior to doing any high-risk sports. They're all your standard warm-ups that we sort of talk about, but we made it into a sort of concise program that was evidence-based. And these videos are available on YouTube. And you can see that these are not sort of unfamiliar, but it's definitely worth having a look. Another one is the Power Up to Play. So they basically go through similar sort of activity, looking at form, looking at different exercises. So if you look up the Power Up to Play, this is a good resource to use. So moving on, so how does it happen anyway? How do you get an ACL rupture? Well, it's a very specific position that it typically occurs in. So it's a dynamic valgus, you've got a bit of abduction, ankle eversion, and femoral adduction. So, but in reality, patients don't tell you they've had the valgus abduction at the knee type injury. They typically say, it was a non-contact injury. They felt a twist as they were coming down the slope. So it may be that the powder's not very good, or they've hit a slippery patch. They felt a pop in the knee. Swelling. Now, it's really interesting, depending on what textbooks you read, there's always variable sort of advice given about swelling. But in my experience, swelling doesn't always immediately happen. It can happen, and it probably happens most of the time, but swelling can be present even 24 hours later. A lot of these patients will also tell you that they can't weight bear. So they need something to take them down, someone medically trained to help them get down the slopes. Interestingly, just talking about the endurance and being prepared for these ski holidays, more often than not, the patients will tell me that it happened on the very first day they were there. So how do I manage these patients? Well, the first thing is to inspect the knee. Often it's swollen, they have a bit of a fixed flexion, they can't fully bend the knee. They usually complain about generalized tenderness, but specifically on the medial side, you might be worried about a medial collateral ligament sprain, or indeed a meniscus tear. When you're looking on the lateral side of the knee, it may be that there's an associated posterolateral corner injury, or indeed, once again, a lateral meniscus injury. Brent, when you're examining these patients, is there anything else that you're specifically sort of looking at and focusing on?
No, I think in an initial, the swelling and the palpation are the big thing, but I think we'll get into it a little bit more in the future. The more the specific testing will be the next thing we'll be looking at. Yeah.
Okay. So he's nicely led me on to the special tests. So the main purpose of the ACL is to resist anterior translation. Believe it or not, the ACL is really responsible for a lot of rotation around the knee joint. So the tests that we do include the Lachman test. Now, this was filmed a few years ago. It was my daughter and kids. It's just so easy to examine them because there's naturally a little bit of movement in the knee joint. But you can see that the knee is flexed to around 30 degrees. You let the tibia sublux posteriorly, and what you're applying is a forward pressure and just seeing how much the tibia comes forward relative to the femur. The other test is the anterior draw test. Now that's done at 90 degrees of flexion. I'm not a big fan of this test because if you see, the whole leg moves forward. And that's partly explained by what I was demonstrating with the anatomy earlier, that a lot of the surrounding muscles are recruited when you do this test. And actually it's not as sensitive. So in my hands, doing the Lachman test is far more sensitive. And then the final test is the pivot shift test. Now, this is a complicated exam. It's often difficult to do in clinic, but it's certainly doable. And I do this in clinic because it gives me an idea of the extent of the injury. But in a nutshell, you hold the leg in internal rotation and in extension. Then you go into a applied valgus force and take the knee into flexion. So if you feel pop, that's the knee reducing back into position, and I'll show you an image of that later on in my talk. And in a negative test, there's no change in the position. But just to give you a flavor of what it looks like, this is it. So hold the leg internally rotated with a valgus force and go from extension to flexion. So this, as promised, this is somebody we've done ligament surgery on, who came in with, you can see a lot of hyperextension on both sides. And as we go into flexion, the knee just pops. I'll show you a slightly better angle from the side. So applying an internal rotation, valgus force. As we go into flexion, once the glare pops away, you can see, bang. Okay, so the femur sort of subluxes forward, but the tibia is actually reducing back into an anatomic position. This patient actually had an MCL injury as well. So in full extension, you can see the leg really opening up in full extension, which it should never do. But in 30 degrees of flexion, it opens up even more. So this is a high-grade ACL injury and MCL injury. The reason why I specifically wanted to demonstrate this video is that there is a thought that you can't do a pivot shift test if you've had an MCL injury, but actually you really can. It shouldn't stop you from getting an idea of the pivot shift. So, Brent, anything on examination so far?
No, I don't think so. I think for me as a physio, a lot of it comes from the subjective. When someone comes in and tells me how the injury happened, usually that's a good indicator as well. But yeah, the swelling is sometimes there, the palpation, and then those special tests can usually give a pretty good picture as to what's happening.
Yeah, so it's what I always tell all my sort of fellows and registrars, that actually it's all in the history. So if you take a good history, more or less you'll come to an idea of what's going on. So that's the key part.
Yeah.
So initial management, look, this hasn't changed since I, started my training. Get on with the RICE, rest it, ice it, compress it, elevate it. It's so simple, but you'll be surprised how a lot of patients don't necessarily follow this, but it is a really good way of just getting the knee to quieten down. So everyone has different views on splints. Now, a lot of patients will go to the emergency department and get put into a cricket pad splint, which is certainly, in the very immediate sort of post-injury period, the right thing to do. But my job and my sort of feeling is to get them out of that cricket pad splint as soon as possible, just to get a bit of movement in the knee. What are your thoughts, Brent? Do you like those cricket pads? How do you manage them?
I tend to prefer it. It's all very patient specific, but if it's not excessively painful and it's not particularly functionally limiting, it's good to try and not use the splint, because that's how you're going to keep mobility and how you're going to keep strength around the knee in particular. Yeah, there's certainly, splinting has its place, but it very much varies case to case for me. Yeah.
So the hottest thing, I would say, for me, particularly in the last few years, has been looking at arthrogenic muscle inhibition. Now, it's a really interesting topic, and the reason why it's interesting is because it's directly related to how quickly and how well a patient does when they have an acute knee injury. So, in a nutshell, arthrogenic muscle inhibition is a reduction in the quadricep function because of the acute knee swelling following an injury. The main sources of this inhibition is one, related to a local swelling and effect of inflammatory fluid on the knee. So the patients will just go into this, situation where they can't flex they can't tense the quadricep muscles up. They just become completely quiet. There's also a spinal reflex, so a local circuit around the spinal column, but also supraspinal, so more sort of central related issues. So when I see a patient who's got an acutely painful swollen knee, my aim is not to take them to theatre and get them operated on and get them going. It's often the opposite, is to bring the swelling right down so that they can start activating their muscles. Because if they go into a surgical situation with that sort of situation, they will do really poorly after surgery because they've had such poor muscle function pre-op. So the way that I do that is get the physiotherapy team involved. I often utilize cryocompression, so cryotherapy and compression. There is some evidence for electrostimulation, but it's not sort of high level evidence. And you can do sort of taping and splinting and things to help with bringing it down as well. One thing that I've done more recently is actually taking the fluid off the knee joint in the clinic. So if these patients come with an acute large hemarthrosis, I will often put a needle into the knee, take all the fluid off, put a bit of local anesthetic in, and that's it. And then send them away to sort of get a range of movement and swelling management started. Brent, what are your thoughts around arthrogenic muscle inhibition? Is that something that you sort of see a lot?
Yeah, it is something that you do tend to see. I wouldn't. It's almost not just specific to the knee either. It's going to be all over the body. But if there's pain there, that very much has a massive impact on the way that the muscles are going to work. And swelling, if that's something that's restricting how much movement that can happen.
Yeah.
You certainly. It's very quick that you can lose that function around the muscle and that strength.
It's pretty impressive, isn't it, how quickly that can happen?
Yeah.
So yeah, this is how I do it. You can put a needle in from the medial or lateral side, and it's not unusual to have, sometimes 50, 60 ml of fluid that comes out, and patients often feel a hell of a lot better once that's been done.
They can probably move a lot better as well.
Yeah, exactly. Stops it being so stiff. So look, X-rays are useful. I think sometimes you can have a bony injury, you just want to rule out, but an MRI scan, as we know, is the gold standard, and it can basically guide your treatment towards physiotherapy, brace therapy, acute surgery for displaced cartilage issues, and whether you are going down the sort of which route you're going to go down. So I thought it'd be useful to show you an MRI scan. This is an MRI scan of the knee. This is a sagittal view. You can see there's fluid in the knee joint. There's bony bruising in the distal femur, typical impaction injury on the femoral condyle. That is pathognomonic for an ACL rupture when you see that pattern of bruising. And indeed, there is a ruptured ACL there with a normal posterior cruciate ligament. And as we go to the medial side of the knee, we look to see if there's any other meniscal pathology. Once again, lots of fluid in the knee, a huge effusion. You can see that bruising on the lateral femoral condyle. There's the medial collateral ligament, a bit of fluid around the lateral meniscus. And this is the course of the ACL from the front. And the ACL's torn. Menisci looks fine, and we can once again see that bony bruising on the scan. So what do we do with ACL injuries? We've spoken about the initial management. We're now looking at the non-operative management of ACL ruptures. This is a really good paper, an MRI-based study looking at a bracing regime to try to get the ACL to heal. And this demonstrated findings at 2 years and 5 year follow-up. And when they looked at the outcomes, they found that a lot of these ACLs can go on to heal. And if you look at the MRI scans, it's quite compelling, the evidence for this. So here you can see a bit of the ACL coming up, but at its insertion, it looks completely torn. At 3 months, you can see, compared to the one at baseline, the effusion's really gone. The sort of severe inflammation around the knee has settled down. But at 26 months, that looks like a normal ACL. And this is not just a one-off. This was consistent findings throughout the series. So there's a lot of these. Brent, what are your thoughts about bracing therapy for ACL ruptures?
I think there's a lot more of it happening now than there has been previously. Like you're saying, as there's more research going into it, there's more evidence coming out to support it. It's hard to argue against it. If the body's certainly capable of regenerating the ligament and getting back to normal, it's always going to be a good thing if we can have that happen. It's the tricky thing is how long it takes, and if someone can tolerate or maintain or live a lifestyle that they want to in between it recovering to where it needs to be.
Yeah, and it is all really patient guided, isn't it? So, it's a conversation with the patient, what their expectations are, and, how they, do the cross bracing protocols and things like that. So it is very much driven. It's a sort of combined decision, isn't it?
Yeah, exactly.
So prehab, so someone's had an injury, you're either going to sort of rehab them to full recovery, or they've decided they want to have surgery at some point and you want to get them ready for their procedure. Look, if you're going down the non-operative route, it can't be a sort of halfway house. It needs to give it a proper go. And to my mind, it's a minimum 3 to 6 months of going down the rehab route and seeing if you're going in the right direction. Post-op, so if you've had an ACL reconstruction, for me, it's normally 12 months, but you need a minimum of 9 months for rehab with no pivoting sports until 12 months. And we know there's a high incidence of ACL ruptures on the contralateral side, because patients will often focus on just the side that they've had operated on. So it's really important to also train the uninjured leg. So the way that I'd be really interested to get Brent's thoughts on this, but the evidence for me demonstrates going down the accelerated versus non-accelerated rehab. My patients, if they've had a straightforward ACL reconstruction, it's usually unrestricted, immediate range of movement. I like immediate weight bearing versus delayed. When it comes to open kinetic chain exercises, I like doing that early, but sort of within a limited range so that we don't bother the ACL too much. But I'm really happy to do early closed kinetic chain in all ranges of movement. But what do you think? Is that consistent with what you think?
Yeah. I mean, a lot of what I do tends to be done based on what you're telling me is allowed to be done.
Yeah.
But in terms of, we mentioned before as well, a lot of the time ACL injuries aren't necessarily just happening by themselves. So sometimes there's the other considerations of, was the medial or lateral ligaments injured, or was there a meniscus injury, and how that was repaired. But yeah, a lot of it becomes, as well as the movement can be and as well as the weight bearing can be is initially, that's always the goal for myself.
Yeah. And I when I was doing my training, it used to be routine to not have patients weight bearing for a few weeks, even after just an ACL reconstruction, and also put everybody in a brace. So I do restrict patients who've had meniscus repairs and things like that. But if it's a straightforward ACL or perhaps with a tenodesis, I'd still get them weight bearing with no brace. I think that really sort of helps to accelerate the rehab.
Yeah, exactly. It gets the muscles working as soon as possible, which is kind of what we want to see.
Yeah. So, okay, let's talk about operative management. I've included the sort of pediatric piece on this, and I think it's quite important that pediatrics a little bit different. I think they do poorly if they have persistent instability in the knee relative to adults who can normally a lot of adults can manage. Particularly in the pediatric population, there's a risk of developing a medial meniscus tear if they have persistent instability. And certainly, look, from a mental health perspective and development perspective, if they're not participating in sports because they've got ongoing instability, that obviously can have an effect on self-esteem. I've mentioned character development. These are important factors that we don't always necessarily think about in knee surgery. We know from one of the largest studies done in Australia, so Leo Pincheski in Sydney looked at his cohort of patients, over 5,000 aged between 9 and 69. And what he found was that if there was a 5-month delay in persistent sort of instability patients, there was a 2-fold increased risk of getting a meniscus injury, and that went up to 6-fold if the ACL reconstruction was delayed by a year. And the argument, particularly in the pediatric population, is that risk in both of those timeframes will double if you're under the age of 17. So what's changed? What do I do differently? What's the sort of newest techniques? Well, actually, this is not that new anymore. It's been done for quite a long time, but it's still not widely necessarily used. I use a single quadrupled semitendinosus rather than a doubled semitendinosus and gracilis for my graft. I also do use quadriceps for patients, and it's usually, once again, a conversation on what the patient wishes to be able to do afterwards. So if they do jumping sports, you don't want to necessarily, basically anything that's hamstring heavy, you don't want to necessarily be using their hamstrings for their reconstructive surgery. Why did I change to quadruple semi-T? Because it reduces the amount of hamstring pain patients get. So one of the main complaints following ACL surgery traditionally has been the pain along the back of the thigh where the graft has come from. The other reason is that you continue to have some hamstring function. And because the semitendinosus, if it's folded over twice rather than once with the gracilis, the semitendinosus is a bigger graft in itself. So we know that if you have a bigger ACL reconstruction graft, the risk of re-rupture significantly reduces. The other couple of things that I've done in my practice, once again, these are not new things, they're just not routinely used, is that I tend to preserve the old ACL if I can and pass the new graft through the old ACL. And the other thing that you can do is compress the graft when you put it in. So this is just a picture of surgery. So this is, just orientate yourselves, this is the old ACL. We're just passing a pin through the old ACL, which is ruptured from the side wall of the femur. You can see it's lax, and here's the new graft going through the middle. And when you get MRI scans, they're really impressive to see because actually they look like really quite mature grafts because you've used the old ACL to give it a bit of nutrition around a new graft, also give it a few sort of proprioception, so it really helps with the graft healing. What about associated injuries? Now, we've spoken tons on ACL because, to be honest, that's the majority of the patients that we will see. We will often see associated injuries as well. So this is the meniscus, the lateral meniscus and the medial meniscus. More often than not, we see posterior horn meniscus tears. Now, you may have come across the root, so the posterolateral root and the posteromedial root. If you injure the root on either the medial side or the lateral side, that is as good as having a complete meniscectomy of the meniscus, because the whole meniscus stops working when it's injured at this level or at this level. In ACL surgery, once again, something that isn't routinely looked for, but I do as part of my procedure, is I put a camera into the back of the knee to see if they have something called a ramp lesion. And I'll show you a demonstration of that in a second. We know that if a patient has a high-grade pivot shift, they will also have an injury to the back of the knee at the ramp level. And it can be in patients. Meniscus tears occur in about 2/3 of these injuries. So you must go looking for them. So this is what a meniscus tear picture would look like, a torn meniscus, and this is just sutures going in there. And now there was a lot of controversy about meniscus repair surgery. So here's a repaired meniscus. And this is the perfect kind of patient for a meniscus repair. The cartilage is normal. It looks like young, healthy cartilage. And fixing this back in place, they will do well. And the analogy for that is a good shoe. The heel's just come off, and you want to fix it back in place. But if you've got this knee where the cartilage doesn't look so healthy, you've got a degenerate-looking meniscus tear, which is in multiple fragments. It's a bit like an old trainer that needs to go in the bin. So this kind of tear would simply be debrided, and you wouldn't be attempting to repair that. So what is a ramp tear? Well, this is a view at the front of the knee where actually when I put a probe in, the meniscus is not moving forward. So you can easily be deceived to think that this meniscus is normal. But when you pop a camera into the back of the knee, and you probe the ramp, you can see there's a tear here at the back. And if you don't go looking for this, you won't find it. And these are technically fiddly to do, but incredibly rewarding, and they significantly reduce the risk of re-injury. This is how it looks. So here's just a needle going in, knowing where we are operating. This is just a shaver, just preparing the meniscus. And then we just simply put in usually 2 stitches to hold it together. We know that if you do it, that if you have a high-grade pivot shift, up to 47% of patients may have a ramp tear. So it's really worth looking for. I mentioned the root. So if you injure the root of the meniscus, once again, challenging to repair, really easy to remove. But if you don't repair them, your knee is condemned to osteoarthritis. This is what a root tear looks like. So here's the femoral condyle, here's the tibial plateau, this is the meniscus coming round, and this meniscus should be attached to the base of the tibia here. Once again, here's the meniscus, it's no longer attached to the tibia. So what we do is I put a couple of stitches in to hold it all together. I make a new socket, which comes out over here, and then you can see just with a couple of stitches going through the bone, we can reattach the meniscus to where it should be. And this is really important to do. So now we've done the ACL surgery, so we've spoken about non-operative management, we've spoken about prehab, we've spoken about ACL reconstructive surgery, we've spoken about associated knee injuries. But where else are we at the moment in trying to reduce the risk of re-rupture? Now, we know that the ACL is really good at stopping AP translation as well as rotation, but at rotation, it's not really good at controlling it because it's in the middle of the knee joint. So if you want to control rotation around the knee, putting a ligament in the middle of the knee joint is not a great place to put it. You'd rather put it on the outer side of the knee, so you've got a bigger, wider circle to control, and certainly it's a stronger resisting force. So it's a bit like having a wagon wheel. If you try and stop this rotating and you're trying to stop it at the middle, you're not going to be very effective. But if you're stopping it on the outer side of the wheel, you're going to really be able to resist that movement of the wheel. So the lateral extra-articular tenodesis is something that's been really huge, particularly in the last 10 years. And we know based on the stability trial that you can reduce the risk of re-rupture down to 4%. And without it, it can be as high as 11% in an adult population. I do it for all of the children I do ACL surgery for. I do it in all of my professional athletes if they've got a high-grade pivot shift, or indeed if they're having revision ACL surgery. So these are the key people that you need to be sort of looking out for to see if they are the right kind of people. And the reason why I don't do it for all comers is because it's another thing to have to recover from, and not everybody needs to have more surgery. So that's sort of coming to the end of my talk. Just to summarize, I think it's really important to do a thorough clinical assessment. Using early investigations, really, I'm a strong believer knowing what the diagnosis is can really help to direct your recovery. I work closely with the physiotherapy team to optimize both non-operative and operative outcomes. Have an informed discussion with your patients. You know, not everybody will know what route they want to go down, and you've just got to keep them informed and ultimately guide them, and they can come up with a decision. This goes without saying, use of modern surgical and rehab techniques for optimal results, and more importantly, to use an evidence-based approach. Brent, before my final slide, is there anything else you want to sort of add to the kind of summary of that?
No, I think either way, in terms of physiotherapy, either way you go, whether it be operative or whether it be non-operative, it is a longer rehab process, and it takes a lot of commitment and effort over time to get a really good outcome. Certainly the outcome will come if the work gets put in, but yeah, it's a really big job to rehab, specifically from an ACL type injury.
No, it really is, and making sure that the patient knows that from the beginning is all part of the counselling process. And so, you know, when you can manage the expectations like that, it makes for a much smoother journey.
Yeah, exactly.
So that's me. Keep in touch. These are my different profiles. You're more than welcome to follow me on and to see what I'm up to. That's my email address, website, and if you need to get in touch, I'm sure Hattie will share details, and that's our sort of clinic phone number. I'd love to hear from you. If you are a clinician, physiotherapist who wants to refer patients in, we also often have, we organise visitations to the hospital, and you can sort of follow the pathway with your patient, providing we can get all the relevant permissions. It's not unusual to have people in theatre seeing the procedure if needed. But yeah, it'd be great to see you. Thank you.
Thank you both. There's been some questions in the Q&A function section, if you have are happy to answer them.
Yeah, so, okay, I'll start from the top. How important is physiotherapy to recovering from a knee injury? How do I find a good physiotherapist? Brent, I'll hand that over to you. Yeah.
Well, the physiotherapy team at the Cromwell Hospital, which I'm a part of, are particularly good. So I would very much recommend them. In terms of how important it is to recover from an injury, it's crucial. It's crucial. Whether it be rehabilitating the injury itself and getting adequate strength and endurance or control around the knee, but elsewhere through the hip or through the core or through the ankle, it's very, very important. But then there's other injuries which can happen sort of as a result of a gradual build up of load, which to that point you then need to go back and unpack why it's happening and then address those causes too. So really, depending on what the injury is and what the cause is or how it's happened, the physiotherapy is very, very effective and useful in terms of getting a full recovery and getting you back to doing what you really want to do.
Yeah, I totally agree, and I think I certainly can say that the team at the Cromwell are absolutely amazing. So yeah, that's where you can find a good physio. I've had patella alta and I've had several dislocations since I was a teenager. I'm going skiing in January, concerned about injuring my knee. What are your recommendations for keeping my knee safe? So look, patella outer is difficult, and if you've had multiple dislocations, this is probably one of the few times if you do want to go skiing that I would say some of these patellofemoral braces can be handy in this situation, just to give a bit of protection around the patella. Patellofemoral problems are really complicated, and that's one of my sort of subspecialist interests, because it's not just usually the height of the patella, it's often related to the rotation in the bone as well, and the position of the patella relative to the tubercle. So it's quite complex. But I think getting good prehab beforehand, making sure you're properly strengthened and conditioned beforehand, and you can consider a patellofemoral brace during the skiing period. Brent, anything that you would do differently?
No, I very much agree in terms of that. Improving that in terms of that prehab, getting really good control around the knee, in particular to minimize the risk of that the dislocation. Strength.
Now, the next question is a really good one. My patients ask it all the time, and I'm going to give this to Brent because actually I say to him, well, when the physio says you're ready, and it's so how do I know I'm okay to return to sport after ACL reconstruction?
So in terms of a return to sport, a lot of that becomes protocol or protocol guided or meeting set criteria in relation to strength, in relation to endurance. A lot of it is trying to match up to the other side at the same time as well, because there's a loss of strength that's going to happen from the surgery. You need to be getting back to at least a baseline. So it's meeting criteria, meeting strength levels, meeting endurance levels, but also stability and control when it comes to a lot of different movements. If people are talking about getting back to sport, and I don't know, maybe it's swimming, that's going to be a lot different to what it would be if you're going back to football or going back to tennis. So it becomes a little bit more sport specific as well. But having adequate control in a number of different movements and having adequate strength as well to control those movements is a lot of when it comes to it. And like you've said before, Rags, it's a minimum of 9 months, but more often than not, it's sort of a 12-month process to get back to that point.
Yeah, brilliant. I couldn't agree more. So what is the first thing to do if you suspect you've had an ACL injury while skiing? So the first thing to do is basically manage the pain and swelling from the knee, and get yourself, and obviously it's painful, a pair of crutches can be really helpful. We spoke about splints to try and keep the knee a little bit straight, just to give you a bit of pain relief. But if you suspect you've had an ACL injury, my suggestion would be do the RICE principles that we mentioned. So rest, ice, compress, elevate. Get yourself in front of one of us, and we can organize examination, see what the knee is doing. And if it does demonstrate that there's potentially an ACL injury, we can then organize the necessary investigations. But the first principles, as I mentioned, are about swelling management, pain management, helping you with your mobility, getting all that under control. Then we can take things from there.
And just to add to that, I would say if you suspect something's happened, don't try and be cavalier and jump back out on the slopes the next day.
Yeah.
As much as it would be disappointing to miss out on the remainder of your ski trip, if the ACL is injured and then you're out there and you're active and you're doing more, it exposes a much greater risk to bigger injury, or other injuries as well.
Yeah, so I call that a secondary injury. So you've had these already gone, and then you've not done a meniscus injury, you've ruptured your ACL, but then you go ahead and have a second injury, and then you tear the meniscus. So yeah, that's really sound advice. Just stop. And that's what I meant by the first day. It's often first day patients will say, look, I only just arrived and I did the injury. So yeah, please don't carry on. And then finally, can an ACL injury in childhood cause lifelong problems? So look, it just goes back to my point of looking at that paper demonstrating that actually if you do have an ACL injury, your risk of having a meniscus tear later on down the line, ongoing instability, micro movements along the cartilage, if you're not managing it, then yes, you can have lifelong issues. Obviously, that's not not one size fits all. It can some patients who don't necessarily do sports or otherwise have a very sedentary sort of life may be absolutely fine. But generally speaking, in a pediatric population, they're going to be really active. So I think it can present challenges in the future. I think this will be the final question. So are spring-assisted knee braces like the Mojo or similar effective in reducing the risk of injury, especially in older skiers? So my thoughts are, yes, I have patients who do use braces prior to skiing. The only thing I say is please don't be lulled into a false sense of security. You can still injure your knee whilst in these braces, because the speed that you're going at and the impact that you might slip and fall, but certainly they help. A lot of my patients will use them after ACL surgery as well, just as a precaution. Brent, what are your thoughts about these braces?
Yeah, I think a brace is an aid, but it's not the answer. Sometimes it can help, but you still need to have the conditioning around to ensure that your body's not reliant or dependent on the brace, because if it becomes that, then bad things can happen potentially.
Yeah, agreed. Yeah, that's a good way. That is an aid rather than the answer. Yeah, I like that. I'm going to use that. Perfect. I think that draws us to an end. I think we're really on time, so that's really good. Thank you so much to everybody who attended today, and those of you who are playing this back afterwards. I really hope that's been useful for you. And as I mentioned in my slide, more than welcome to come see us one day, or if you want us to help with anything, please do get in touch. So thank you for your time.
Thanks, everyone.
Thank you very much to our wonderful panel today. I'll just leave the slides up for a little bit longer in case anyone wants the details.